Thank you. Thank you, Sanjeev, and the organizers, Dr. Vanita, Dr. Kumar, and Dr. Vijay, for giving this opportunity. My colleague from the ethics committee. Sometimes for the ethics also difficult. So I know 2008 I started my journey in oncology. Before that also I used to treat patients. And in usual conferences of oncology, we see usually those curves. With A treatment, the curve is nicely improving. And I always used to know, are we translating this survival into our patient, my patients or Indian patients? And strictly no, my answer used to be no. And then after a decade, Dr. Vinita published her own research. We talk about this immunotherapy. I practice in town, which is supposedly an area where every patient should have a great access to the treatment in terms of the finances. But including those patients, actually, if you look at a treatment called as immunotherapy, 97% of the patients are not having access to that. So it's not only the availability, it has to be accessibility. And even in Tata Hospital, I observed, because 10 years back I worked in Tata Hospital, and we all have been trained in such way. The first interest used to be the patient. The patient should get the treatment, irrespective of the financial background. And I have seen the evolution of all the NGOs, right from RCC, Regional Cancer Center, or Apex Cancer Institute like Tata Hospital, or Trust Hospital like Bombay Hospital. I also work in HN Reliance Hospital and Jaslok Hospital and Raheja Hospital. Yes, there are no opportunities where I can send my patient to the charity cell, but there are too many troubles. I work in smaller clinics where we try to support the patient. But again, as an individual oncologist, rightly discussed in the data sharing, and there are so many aspects to it. Most of the time, we end up in getting the burnout. Individual doctor cannot have this luxury of NGOs, social worker in a private practice. And maybe today's topic, which is included for the first time. So I would like to congratulate the organizers. As I said, the routine oncology conferences, we just see the Western data. But the basic problem and how to solve that problem, maybe since last 4 years, Vijay told me it's 4 years, and it's a wonderful workshop. And there are many more workshops, but this something many oncologists should come forward and attend. So Vijay told me you can now attend this workshop as a virtual, but I know I would like to come there. And so basically we'll just discuss what is the problem, and everybody is aware about those statistics. This is our population. No, I should not say about what is our population. And in metros, now the problems of the rural India are totally different. But in metros, what we face, my specialty is more of lung cancer and breast cancer. And in metros, these are the basic problems. The good thing is the best treatment is coming up. In the last 10 years, I'm a medical oncologist. But if you look at the radiation, surgery, and medical oncology, the majority of the evolution or the treatment has come in systemic therapy, which is in medical oncology. Yes, in surgery, you have robotics, you have proton. But if you see what is survival, improvement in the survival is maximally seen with the administration of systemic therapy. The rural area has its own problem. Head and neck cancer is a major challenge in India. So these are the incidences in the top 10 cancers. Breast cancer in the females and lung cancer, oral cancer in the males. Apart from that, the GI cancers are on rise. Now, in the last 2 years, what we have seen, many patients have undergone CT scan for the COVID, and those cancers which we could not have picked up, no early detection has happened accidentally in last 2 years. And now we are seeing stage 1 lung cancer, which used to be a rare entity for us. So then the cost of the surgery and the radiation is also involved with that. So these patients, where are these patients going? I have a luxury of calling friends at Tata hospitals. I can immediately send a pediatric patient. The moment a pediatric patient comes to me, irrespective of the financial background, I try to send them to the Tata, because I know the structure is such a fantastic structure at Tata Hospital. Every patient gets treated, and I have worked over there. So I'm biased. Any patient pediatric comes to me, I'm an adult oncologist. So, but I used to treat 10 years back. People used to force me, you will treat pediatric also. But I stopped. I sent the patient there, and irrespective of the financial background, each and every patient will get the best possible treatment. So this is what the total number of cancer incidence patients have in a year, 1.39 million. And if I look at the Tata Memorial Hospital's file registered number, it is nearly 30 to 40,000, which used to be 20 or 26,000 when I left Tata Hospital. So it is 2% of the total numbers. And if you see those patients who are registered, who are actually completing the treatment is 20% maximum. So this is 20% out of those 2%. Now there are other regional institutes which are growing. If the number is, if I am right, it is around 20 to 25. And if you look at the total numbers which are now registered across all the RCCs is 10 to 15%. And then these 85% of the patients are going somewhere else. So where are they going? They are going either to corporate hospital, big corporate hospital. Good thing, every city, the corporates are taking more and more interest. We know IPOs are coming up, the corporates are growing. Hopefully those corporates should treat more than 10% of the patient free of cost. Trust hospitals. Again, there was an era when the hospital like Bombay Hospital or Jaslab Hospital, the trust patients, the trust used to fund the 100% of the treatment of those patients. Now, as somebody said, now it is very difficult to raise the funds. And in the COVID time, we face major challenge. So those hospitals are also struggling for those funds. But 90% of the patients either have to pay from the insurance or from the pockets. And then the local hospital nursing homes, which is again with the increasing corporates, the nursing homes are also facing their own challenges. So 80 to 85% of the patients are going beyond the regional cancer centers. There are many reasons. There are stigma associated with the cancer. We have to use the NGO sources to make the people aware that the cancer is now treatable. Look at the cure rates in the pediatric cancer is beyond 90%. Look at the stage 1 to breast cancer survivals. It is beyond 90%. So what is the financial distribution? This is very important. If you see the per capita income, the first one, 0.7% is the percentage of patient or the population who can afford anything. It's only 0.7%. And the last graph, if you see, is those patients who cannot afford an average. If you look at all the cancers, and if you look at the average cost, these are the subset of patients who are not going to afford anything in any hospital. And that includes the travel cost also. Somebody who is in Bengal wants to come to Mumbai and stay in Mumbai. Even if I want to treat him free of cost, he has to pay the cost of stay in Mumbai. And the cost of treatment, the stay in Mumbai is rather topic of debate. So for this, so I am here not as a Bharat Bhosle or a medical oncologist from Mumbai. I may be representing those medical oncologists or surgical oncologists or radiation oncologists working in different parts of the country. And this is beyond Mumbai, beyond metro. Somebody who is sitting in the periphery, he will have access to Rajiv Gandhi Yojana, but that Yojana is not going to cover the cost of BMT or a treatment like crizotinib for lung cancer, where we see even stage 4 lung cancer patient with a brain metastasis are going to survive for beyond 5 years, which was not possible years back. So there is definitely a need of collaboration, and it is just not for the sake of fundraising. There are many more things we can do as a collaboration. And probably the private sector and NGO should come together in each city, in each rural area. What we can do is the screening camp. Vandana ji, I know you more than a decade, and we have been part of awareness program in the private sectors. So we learn that screening, there are going to be no obstacles where a doctor cannot always go and talk to the patients, where we can use you as a force to go to the root level and educate the people. Unless and until we detect the cancer in early stages, definitely our cure rate goes up, but the cost of treatment also goes down. If you look at the breast cancer early stages, and if you pick those hormone receptor positive breast cancer in early stages, which is almost 50 to 60% of total breast cancer patients, by giving simple hormone therapy, which will cost few hundred rupees, you can simply avoid the chemotherapy. You avoid the toxicity also. So this is the importance of screening and penetration of screening to the root level. Support of surgery, radiation, chemotherapy, targeted therapy. This is never-ending cost. So I get support from the individual patients. I don't have no conflict in terms of NGO. But many patients know, those who survive, those who do not survive, the family come forward. They directly give us call that we want to support the patient. Who are needy patient in front of me or no, many oncologists do the same thing. They directly ask the patient or those families to support the patients. But then the cost of treatment varies. It can be a simple port insertion, or it can be a BMT cost of 8 lakh rupees or 10 lakh rupees. Support for travel and assistance. That is a major problem. Somebody who is in the periphery of Maharashtra coming to Mumbai. I was talking to family with a good financial background. So coming to Mumbai is something which is a big fear in their mind. So they want to go to a nearby place. So you have to penetrate to that level. It is not only strengthening the hospital in Mumbai. Support group formation is very, very important. Many of my patients who are of breast cancer, they form their own group and we tell them. So there is an anxiety in terms of getting the treatment also. And then after completing the treatment, there are so many factors, they don't open up in front of you. So if the support group is led by some NGO or a social worker, that really helps them and motivate the other patients who are no attrition rate is very high. With a simple single chemotherapy, if the patient gets side effect, many instances I have seen the patient is not coming for the chemotherapy. That's why we end up in giving call to the patient. It's not that you come to me only and take treatment with me only. No, it is always every oncologist should tell the patient wherever you go, you complete the treatment. That is very important because that is going to translate into the survival. Support for education. Those patients who complete the treatment, who are young, or somebody who is the leading member of the family and terminally ill patient passes away. The entire family. So I look at not only my patient, but the entire family as my patient and the family, because you have to plan your treatment looking at the patient's family. If somebody who is 80-year-old terminally ill and the patient has only one relative who is already bedridden, we can't force the patient to come to the hospital. It is not feasible. You have to plan such a holistic treatment which can be delivered at home. So home care, home treatment is also coming in a big way, which can be developed with the help of the NGOs. Now, support of end of care. So this I have faced many times and I have personally looked into it. Simple problem like getting a death certificate. Even after the death of a cancer patient, the family is roaming around to get a death certificate. Hospitals have their own legal issues, they cannot issue them. So the palliative care has to start not only to give a good quality of life, but there are so many problems where the family suffers. So end of care is also important where you can play a major role. And then information dissemination. This is very, very important that now we can treat a cancer. There is a cure to majority of the cancer in the pediatric age group and early stages. And this information needs to go to each and every individual. They should come forward for all the aspects, right from the screening, then treatment and completion of the treatment and regular follow-ups. So these are the things which a patient should complete, then only that cure rate is possible. And this is not possible with the only oncologist or surgeon or a radiation oncologist. Every individual, the NGO, the social worker and the family person, right from that sarpanch of that village and the teacher, everyone should be included in this journey. And then I think what I used to feel that these survival graphs are merely shown in the Western countries, any GM paper or Lancet paper, unless until we work on the ground. This survival graph, I don't accept it. This is possible with your involvement, and that is why this workshop, I again congratulate Vijay, Dr. Vanita, the social worker team and the NGO team, and my colleague from the ethics committee is also here. So this is possible. One fine day, and I am very happy within 10 years, within a decade, this is possible. And our cancer journey is not only one decade; it's long, 100 years evolution of the research, and you play a major role in bringing down the pain or the suffering of the patient, and will definitely lead towards that 100% cure rate for all the patients. Thank you for the opportunity given. Thank you. So, but there is no question. We want more.
Yeah, but don't say that this breed is facing extinction.
So I am the only person who is looking at more and more NGOs should come up. And that 10 to 20%, I would say.
Yeah, exactly. Thank you.
Thank you for that.
I want to meet Vasif after 10 years.
So see, as I said, there are. So 1 minute, can I take 1 minute? So as a student in Tata Memorial Hospital, the only thing I entered the Tata Memorial Hospital. I was talking few days back. I am in Bombay Hospital. In 3 years, we used to just work. The only thing which our teacher used to tell us, there was nothing like teacher is telling us. It's like you imbibe what the other person is doing. So the only thing is in our mind, a patient comes and if there is some percentage we can cure it, we used to do anything for it. And Mr. Ganpati, we used to go to the NGO department, get it registration. We used to fight for the bed. We used to fight for the funds. A patient goes to ICU, a pediatric patient. Brijesh was there. Dr. Brijesh is my senior colleague. So I have looking at the teachers only, the students get trained so much. But the moment you come out of Tata Memorial Hospital and you go into the sea of these metros, it's difficult. We want to do continue this good work, and there I see there is a lack of all this structure. And this structure needs to be developed at every level. I'm not saying only at Bombay Hospital or District Hospital. It needs to be developed even at the rural area. This is not just for the funds, but this patient needs to come to the tertiary hospitals. A patient of AML, you can't treat in a periphery center. He or she has to come to the metro city. Because we know in a treating APML patient, the cure rate is 99%. But yes, the chances of losing the patient in the first month are also very high. That's why the patient needs a treatment in a bigger hospital. Then the issue comes travel, bringing those patients to Mumbai and stay, where we all can help each other.
A lot of things that you said resonated with me. I'm a palliative care counselor and a survivor myself. And one of the things, I get calls from all across India for emotional support. One of the things that's missing in our country is support groups. I get individual calls reaching out, and I'm spending time with individual patients. If we are able to create more support groups, we'll be able to resolve the emotional suffering of a patient a lot. So I think as NGO partners here, we can together, if we can work at creating support groups. I speak from a survivor's point of view, that it can actually, it helps in the survival. It adds to the survival abilities of a survivor. So that's one point that I wanted to make.
I agree totally. I have personally actually, so many of my breast cancer patients, sarcoma patients, there are sarcoma groups, there are breast cancer groups, where the patient not only reduce the anxiety, but also starts raising the fund for those needs. So there are many things can be done through the support group. So I have mentioned one of the points in we should have a support group, a disease specific support group, and you guys play an important role in that. Because as a clinician, my job is to not see the patient gets the best possible treatment. And if I go beyond this, and which we are doing it, then comes the burnout, because we are also human beings. Looking at suffering some patient who is dying just because of lack of fund or the access to the right center. Many times I do it, see, don't take treatment with me, please go to Tata Hospital. This is the best place where you can be looked after all the angles. Many people have refused. Then it is my responsibility that the patient should get the treatment. Then I have to run here and there. I have called so many times, We Care and the other NGOs, please arrange the funds. But I can't do it for each and every patient. Good. I want to do it, but there are certain limitations.
All right.
Thank you.
Thank you so very much.